everyone. We're really excited to be with you here at the National Rural Healthcare Association Now virtual event. We'd love to be with you there in person, but we understand it's such a crazy time that we're living in, and so equally as thrilled to be here online. We're going to spend the next about 20 minutes or so really talking about the challenges that you face in the rural healthcare environment and really digging into some of the specifics around that, and perhaps bringing some conversation to the table that talks about tools that can help support you in the support of your communities. My name's Amy and I'm part of the clinical team here at the Butterfly Network, but I have a true expert here with me, someone who knows a lot about and works indeed in this very environment that we're talking about. So I'm very pleased to introduce Dr. Kevin Liu. I'd love, Kevin, if you could give everyone an explanation about where you work and the lens that you have on this particular topic.
Sure. My name is Kevin Liu. I work in a variety of environments, including military. You'll probably see in the slideshow where those places may be. But I've worked at a couple different rural environments in which I'm an emergency physician, and I work in places where really there's no ultrasound at all. And I found myself in a situation in which I trained in emergency medicine and got used to ultrasound, then ended up going to these smaller places where they have need with the medicine providers that wear different hats, where they're in clinic first, and then they go work in the ER during the nighttime or something like that. And what they're seeking from me is to kind of advance teaching and education and bring to the table some things that they're not necessarily used to. I will say in Southern Tennessee, really what prompted me to buy an ultrasound on my own. And previously I had previous experience with using the butterfly ultrasound when I was in military special operations. I had bought 3 of them and put them across my unit among my medics. And we use them on Austere environments anywhere from Africa, Iraq, Afghanistan, and different other areas across the world. And we were finding, that is the only imaging modality that we had to try and figure out when somebody needed to go somewhere, when we could keep somebody somewhere. There's a lot of parallels that I could see between austere military medicine and in southern Georgia where I've worked before, where I'm the only doctor there during the nighttime for an entire 20-mile radius. That's the only person that's awake. In southern Tennessee, I do the same thing. I had a situation in which somebody bounced back 3 times. When he finally saw me, I couldn't figure out what exactly was wrong with him. And I had offered admission to him. He had right lateral hip pain. I remember this very distinctly. And I said, "You're just in a lot of pain. I don't know why." And everybody keeps calling it sciatica. And I didn't have ultrasound. And I looked at him and I said, "I'm going to offer admission." But he said he wanted to go home. He went home. Within 30 seconds of stepping through the doorstep, going home, apparently he had collapsed and started coding right there. EMS unfortunately brought him back in within an hour to 2 hours. And I just remember not knowing how to properly give him more advanced care. I went ahead and I thought maybe it was some strange atypical PE or something like that. I couldn't ultrasound him for a DVT or anything like that. I couldn't code him with putting a probe on the chest. And I said, "Hey, I empirically gave him TPA, but I didn't know if it was the right thing or not." It would have been really strange if I gave him TPA and he had a strange AAA, and that would have been easily seeable on ultrasound. But I decided at that point it was time for me to buy one and then take that on shift on a regular basis. And I've collected, really just in the past 2 to 3 months of owning my own butterfly ultrasound, after not having one for a while since I left military special operations, a repository of a bunch of reasons why it's changed my clinical practice.
And that's really interesting. And you definitely bring a lot to the table. There was a lot there. So what I would love to do, you mentioned a number of things about rural healthcare. Before we dive into some examples that go straight to the point of care ultrasound and how that helps, I'd love to get a sense of why you chose this environment, why rural healthcare is important to you, and just sort of help us understand, why, this occupies your days and with something you're obviously passionate about.
I went into emergency medicine because I like the variety. I like eclectic patient populations. I like my urban patient populations. And I also drive an hour and a half down south to southern Tennessee to encounter that. It's a different type of feel, and you're really on your own. And there's something pretty nice about that, and really changes your practice and your mentality. It makes you feel like you're a comprehensive doctor when you can't be. So really, it started off. I did my first ever moonlighting job was in a rural place because that's the only place that would accept me down there, a little far away. And I liked it, and I liked the nurses. I was working 24-hour shifts. It was like a county with, a couple of stoplights, one of those places. And there were definitely some challenges for sure, really kind of getting creative. And I think like the creativity and the things that I'd had to do to improvise really made me feel like I was more of a real, not just in an academic medical center with all the resources in the world and being able to just consult every little thing out. Just made me feel like I was more of a comprehensive physician.
That's really cool. I think creativity is such a great word. I think we definitely relate to that here at Butterfly as well, really thinking about what is it that's standing in the way of implementing these really important tools? What's in the way of, people having that aha moment that makes them, think about getting to where you are, where really relying on handheld imaging is something that, can really impact. And you mentioned about the communities that you serve as well, and wanting people to have care and feel like they have the best care right within, that 20-mile radius. And I know that you have some specific cases that we could walk through that really show not only how to use point of care ultrasound, so which part of the body that you put the butterfly on and what you were looking for, but also to help highlight why you did it other than patient outcome, why you did it other than, having to get more information in order to make great decisions. So if it's cool with you, Kevin, we've brought up one that I believe is an obstetric case. If you could talk us through that, that'd be awesome.
Yeah, so these are just some fetal ultrasounds that I've been able to play or able actually just onto my phone very simply. Makes it really easy for me to send over to an OB. So the first one on the left, if you take a look over there, this is pretty far along, but it's a case in which there's just almost no amniotic. This is somebody that actually came in. She was about 35, 36 weeks, and she did not know that she actually was pregnant. So she was not established at all. So it was definitely, eye-opening for her. We had to tell her, yeah, if I'm in the middle of nowhere, and I have to show her this, it sometimes is reassuring for them to be able to see the fetal movement, be able to see everything in terms of there's something really, if anybody's ever had a child or has been pregnant, to look at that heart going, because there are recognizable things that you can see there. And then on the right side, if you take a look over there, what you're seeing is me just using Butterfly M mode. And it's just me playing around and finding out that, all you have to do is you can do exactly the same thing that I did on my big ultrasounds that I trained on. Find the heart and, just go look for that pattern where it's going and pumping, and just move it along and fetal heart count. And then you can reliably say, hey, this is my heart rate, and your scant amount of vaginal bleeding, we can go and follow up with the OB-GYN in a couple of days. Things look like they're doing okay right now.
And look, if your clinical practice has ever been like mine, it seems like it's always on Friday afternoon that those patients come in that really don't want to wait until Monday to speak to their specialist, or don't want to, wait a long time. And so I really hear you when you say being able to visualize exactly what you're seeing and being able to talk the parents through that, I can imagine would be really interesting. And you also make a good point about, the reason you did this was to establish, yes, there was a fetal heartbeat sort of on that right-hand image. Yeah. But what was interesting, as you said, then you went to M mode. And again, this was something that really you were just sort of following the steps within the ultrasound. We have another feature now where people can actually hear it as well, if they're not as comfortable with the actual visual side of the ultrasound as well. So you definitely make a good point there.
For sure. I think one beautiful thing about this program is that every single time I turn it on, there's an update. I find something new. You know, you can probably even see towards the end of that, the right-hand side video, I was like, well, what if I just measure the biparietal diameter and then take that and just plug it into an online formula? And I got the same dates that would be appropriate for that child too, or for the fetus. So I'm just surprised by these things that, you know, previously, you know, I don't want to. So when I went into military special operations, we were trying to figure out what are these $25,000 price point portable ultrasounds that we were purchasing. And these are just there collecting dust right now. And what we're going to do with them, you know, they're proprietary tablets and stuff, and the updates don't really happen through your phone like they do, you know, with a Butterfly. And I'm really surprised by these little things that happen every single time, and gets me excited to go on shift and just see what else new I can do.
Yeah, interesting. Access, right? Even when you have a system, right? Even when you have you are lucky enough to have these bigger systems, really at a pinch, finding them and understand, you know, where are they? You know, how can I take that to the actual bedside? Who's been practicing with who's in bed too that needs it, and who's using it right now. So you make a good point about, I always think about the clinical side of it, but yeah, that technical, being able to pick it up and away you go. And we're lucky enough, being a software product, that we listen to you and your peers. And then, as you say, we're able to kind of iterate pretty quickly on the features and things that are really going to be useful.
Yeah.
We have another case here, I believe you shared with us, again, in the interests of having information bedside quickly, keeping people in their communities. I'd love you to walk us through this one.
So this one was an interesting case in which somebody came in with some chest pain and low voltage EKG. Whenever you hear, you know, low voltage EKG, you always think about, hey, should I put a probe on the chest or something like that? You know, got a chest X-ray, showed that it was a very large appearing heart, and asked her a little bit more. She said, hey, in 2010, I went through a bout of breast cancer. This was all of my images. Right now, there's a whole repository of other cases that I talked to Amy about, but all of them have just been in the past 2 to 3 months that I've just been, some of them I don't always save. But I threw a probe on the chest and I immediately saw this. And I was like, wow, you know, there's a very large pericardial effusion. My eyes are good enough to kind of through years of looking at this, trying to see if there was any cardiac tamponade physiology where, you know, the RV, when it comes up, whether in diastole, whether it's compressed down, and there wasn't. So we were relatively stable and our blood pressure was fine. But when I talked to our on-call cardiologist, who's not a, you know, it's a very general cardiologist in this kind of more rural place. He's like, hey, this has got to ship out. You know, this might end up needing a pericardial window in a place that has oncology and CT surgery, and we just don't have that. But I literally texted this to him.
And as you said earlier with the obstetric case, you know, having the ability to see this, because I can imagine this lady wasn't feeling very well, right? It's like, why do I have to go for another 2.5 hours, you know, and to be able to see this is why, this is where we're at. So I can imagine that would have been interesting too. I know that cardiac point of care ultrasound, fast TEE, is something that is a very common use of point of care ultrasound. And I know that you have another case here that really, you know, really drives that home.
Yeah. So these are 2 separate cases. You see this constantly when you see these cases. Past history of both COPD and CHF, and you're like, which is it? Because you know, it could be a cardiac wheeze, it could be a lung wheeze, and you're just not sure, right? So the one on the left is playing a new onset AFib RVR. I think I just saw about a week and a half ago. And then the one on the right is a case in which the person came in. And what I would do is, you know, the first thing I do is I just take a look at the heart, see what the heart is doing, see if there's, you know, a severely depressed ejection fraction, first of all. And then sometimes I go to the IVC. You can see me starting to go to the IVC on the left side. On the left side, if you had noticed, what was happening was In AFib RVR, the typical kind of regular heartbeat. And when I went to the lungs, I didn't see what I see now on the right side, which is just tons of B lines. And if you're not familiar with that is, those are, we call them lung rockets. It's indicative of pulmonary edema in the right context, and they're just shooting down all the way down. And so for the left-sided case, I realized, hey, I'm not going to be treating. First of all, I can give, diltiazem probably because there's not a huge component of bad heart failure, and it's a COPD exacerbation, so I probably shouldn't do beta blockers. And what I did was I treated the AFib RVR with calcium channel blockers. I treated the COPD exacerbation, and he got better. But then on the right side, this is a case in which this person was highly hypertensive, tachycardic, and when I looked at him, I could tell just from the ultrasound, hey, B lines, start a nitro drip, and just put him on the BiPAP, and he got better. But this was all, within really 30 seconds to 60 seconds, I knew what my disposition and my treatment algorithm was going to be based on that alone.
Is it the heart? Is it the lungs? Is it the heart? Is it the lungs?
Yeah,
absolutely. And I think the next case shows that too. I think even as a sonographer myself, I look at cardiac ultrasound and sometimes I think, oh, that's not where I would like to start, even though it's so impactful clinically. Whereas the lung, from a technical standpoint, is a great place to start, in my opinion, in my experience, just because of it's so technically less challenging. And I know you have a great example here.
This is a good case in which this person came. He's a COPDer. I saw him literally this weekend, and chest X-ray came by. He was satting in the 80s. We all thought it was COVID because we all think it's COVID anytime, But he said, "I'm vaccinated." I'm like, "Oh, okay, maybe not. I'm not sure." So he was a guy that the second we shot a chest X-ray, we're like, "Wow, where is the anterior lung of the left side?" And he had chest pain. And what we can do here is we can throw it on the nice thing is I can just go straight to a linear probe, with the same probe. It's amazing. I remember when I first saw Butterfly come out with their like, I don't know if you can just switch from, cardiac to linear on a single probe. Like, I don't believe that. Now I am a believer. This was just in 2018, I remember. And I was like, I don't know about that. But this was in which, we call it ants marching when you see the pleural line in between the rib spaces. If you just kind of see that shimmer go back and forth, that's the lung actually going back and forth. And I took a look at his left side, I took a look at his right side. I'm like, you know what? He has lung sliding on both sides. Like, I don't know about this. Like, everybody's like, oh, we need to put a chest tube in. And I'm like, I don't know. So I said, let's not do this. Let's get a CT non-con. Give them some oxygen and see where it goes. We can wait for a second here, right? So that case was one in which I said we need to not do a chest tube, which if you take a look at this, right, if you read your own CTs, there's a very good indication of why we shouldn't have. If you play that again, that's just a very, very large bleb. So if that patient didn't need a chest tube then, and I placed one, then they definitely didn't need a chest tube at that point right there, because I've just caused a pneumo. So, that was one in which the patient purely had a COPD exacerbation. And it wasn't a dropped anterior left lung from a pneumothorax, and if I had placed a chest tube, or if I even did a needle decompression or something like that, that would have caused a massive pneumo. So I'm glad that we didn't do that. Yeah. And that all came from me doing lung sliding. Yeah.
Good stuff. And I know, you talk about interventions, about chest tubes, about, and of course we know that peripheral IV can be challenging. We know that central lines can be challenging. We know that drainages can be challenging. And I know you have a great case here, again, that may, you may talk us through on the procedural side.
Yeah. And this is a real simple one. I'll use ultrasound for paracenteses, for even really advanced ones. I've had to rely on ultrasound for a coding pericardial effusion that I've had to go subxiphoid for. But this is just a simple abscess right here, where the pustule, that central pustule, and where I thought I might have felt some fluctuance wasn't exactly where the large volume abscess was. And this was somebody that we CT'd. We're going to send over to a main hospital for admission for IV antibiotics. It was maybe a bug bite, I'm not sure exactly, but he had diffuse cellulitis. And what he needed was an IND. And the hospitalist had asked me, hey, can you go ahead and IND this first before we actually, end up having our surgeon consulted on it. And it was like 11 p.m. I'm like, nobody's going to IND this unless if I do it. So I was able to find the large abscess that wasn't underneath the pustule. It was about 1.5 centimeters away, surprisingly, because when you think about it, I guess sometimes the tract that goes to that central pustule, the pustule could be here, but then it can track all the way down here. And it just didn't feel that way. But when I actually, took a look at it on ultrasound, I knew where to cut. So he got his source control intervention, and that was what was important before he got out to the main hospital for admission and surgical consult. And I'm sure the surgeon was happy because he probably didn't have to do anything about it.
Everyone's happy if the surgeon's happy, right?
Yeah, I know, right? Yeah.
Don't mess with them. I think hello to all our all surgeons that might be joining us, all in good fun. I think, again, you make great points, right? Point of care ultrasound is there to support the clinical diagnosis. And sometimes it can maybe change or shift or inform what you're thinking. And certainly it's not there for every case. People such as yourselves, your staff, your peers are doing peripheral IVs, for example, all the time and may not need to do point of care ultrasound all the time. But there are certain examples, and you have some photographs I think you'd like to share with us as well, which are super cool, and appreciate you doing that. They can talk about, sometimes you will need some help, some support, even with something like a peripheral IV. So if we find those photographs and can bring them up, and maybe you can talk us through sort of that through that lens as well.
Yeah. So in my experience, there's almost not a single shift that goes by that I'm not asked by a nurse to go throw in a line somewhere. And it does take some practice. And if you're not too familiar with ultrasound, learning it is something. I will say this, it has actually helped me become better at blind sticks because I understand the anatomy. I know where I'm looking for, and I see different variants of it. And this goes, and it starts with peripheral IVs. You get better at A lines, you get better at central lines if you have those in your practice. But there's some pictures here. I did special operations aviation medicine, and there's different places that I was in. You'll see that the butterfly over here is on a cooler because I was in a place that was over 100 degrees all the time. And it was a nice thing that when it overheated, and I really, all of the portable ultrasound ultrasounds that I had, butterfly overheated very rarely. And what I would do, I just dip it in the cooler and just take it out, and it would be ready to go. Yeah, because it's completely, it's completely waterproof, right? And then that middle picture there is actually me in a Black Hawk over the Gulf of Aden, throwing out a peripheral line into somebody that was severely dehydrated, and my medic couldn't get a line in, and it doesn't really matter for rural medicine, but we're supposed to use very minimal light. So we can't turn on light and scream out, hey, we're here, shoot us down. So the minimal light from the screen coming on, that's why you see green light as well, because green light goes down, and that's minimal white light as well. And the only white light we had was a tiny amount of white light coming from my phone. And that's all we needed to throw in that line for the patient. When it comes to rural medicine, the parallel there is, when you've had, do we need to place a central line? Like, just if you get good at peripheral IVs, and I'm sure there are more and more resources as people become better at this, that you don't need to throw in that central line. You can get your 18 gauge in that AC, and your central line skills will get better as you do peripheral IV sticks and learn how to do those.
Yeah, every day is a learning opportunity. That is for sure. That is for sure. Look, thank you so much for sharing with us, Kevin. I think that It's been really interesting to speak with you about some of the unique challenges about rural healthcare and how to have access to things that, you know, can really change the impact that you're having on a community. So I definitely really appreciate it. Again, we're super happy to be here at the Rural Healthcare Association. Hopefully we'll be able to speak with you again soon and talk about all those other repository of cases that you shared with us. But for now, that's all we have time for. So thank you again for everything that you do for the communities. And of course, for everyone out there watching, thank you for what you're doing to support your local communities. We appreciate you so much.